You have taken some version of these pills for decades. Ibuprofen for the bad back, Benadryl to sleep on the plane, a daily aspirin because your doctor mentioned it years ago. Maybe a blood pressure pill or two that you have been refilling without much thought since your 50s. These are not exotic medications. They are the ordinary ones, the familiar ones, the ones sitting in your bathroom cabinet right now. And that familiarity is exactly the problem. Because the body you have at 60, 65, or 70 is not processing those medications the way it did at 40. The chemistry has shifted. The organs responsible for breaking down and clearing drugs are slower, smaller in some cases, and less precise. And when a drug stays in your system longer than it should, or builds up over time without anyone noticing, the effects stop being therapeutic. They start being dangerous, often without any warning. This is not a rare edge case. It is one of the most underreported medical problems in adults over 60, and it plays out quietly in ordinary homes with ordinary medications that have been trusted for years. My name is Dr. Marcus Evans, and I am a medical doctor and physician. This channel exists because too many people are making daily health decisions without the information they actually need, not because the science is hidden, but because it rarely gets explained clearly in plain language by someone who understands both the medicine and the person on the other side of it. That is what we do here. If that matters to you, consider subscribing so you do not miss what comes next. Now, back to those pills. The danger here is not that medications are bad. Medications save lives every day. The danger is that most prescribing standards, most dosage guidelines, and most of the research behind the drugs you are taking were built around younger adult bodies. A clinical trial testing a blood pressure medication or a common painkiller typically uses participants in their 30s, 40s, and 50s. The data gets applied broadly. The prescription gets written, and nobody always stops to ask what happened to that same drug inside a body that is now 72. What happens is this. The rules change. The kidneys, which filter most drugs out of the bloodstream, lose roughly 1% of their filtering capacity every year after the age of 40. By 65 or 70, kidney function can be 30 to 40% lower than it was in midlife, and that decline is often invisible. No symptoms, no obvious warning, just a quiet reduction in the body's ability to clear medication at the rate the original dosing assumed. The liver changes too. It shrinks slightly with age. Blood flow through it decreases. The enzymes responsible for metabolizing drugs, breaking them down into forms the body can eliminate, slow down, so a drug that used to pass through in 8 hours might now linger for 12 or 16. At the same dose, in the same person, the effective concentration in the bloodstream is higher. And higher concentration means stronger effects, sometimes dangerously stronger. Then there is the shift in body composition that most people over 60 experience without realizing its pharmaceutical relevance. Fat tissue increases relative to muscle. Total body water decreases. This matters because drugs distribute themselves through the body based on whether they are fat-soluble or water-soluble. Fat-soluble drugs and many common medications fall into this category, have more tissue to settle into. They accumulate, they take longer to clear. Their effects extend far beyond what the label suggests. And none of this accounts for what happens when you are taking more than one medication at a time, which is the reality for the majority of adults over 65. The average person in that age group takes somewhere between 4 and 6 prescription drugs regularly, not counting over-the-counter medications. Each drug changes how others behave. Some combinations amplify each other. Some compete for the same metabolic pathway. Some quietly cancel each other out. Or worse, create an effect neither drug would produce alone. This is the landscape. An aging body, a slower clearance system, a changing chemistry, and a cabinet full of pills that were designed and dosed for a different version of you. What you are going to understand by the end of this video is exactly which categories of medication shift from helpful to hazardous after 60, what the warning signs look like, including the ones that get mistaken for normal aging, and what you can actually do about it without simply stopping medications on your own. Because that last part matters. Stopping suddenly is not always the answer. Understanding is, and the understanding starts with what aging actually does to drug metabolism, in more specific terms than most people ever hear from their doctor. Here is something that does not get said clearly enough in most medical conversations. The dose printed on a pill bottle was not calculated with your 68-year-old kidneys in mind. That sounds like a small technical detail. It is not. It is the foundation of everything that goes wrong when older adults take medications that were perfectly safe for them 20 years ago. And to see why, you have to follow the drug through the body, step by step, and watch where the aging process quietly intervenes. When you swallow a pill, it moves through the digestive system and gets absorbed into the bloodstream. From there, It travels to the liver first. This is called first-pass metabolism, where enzymes begin breaking it down. What survives that initial pass enters general circulation, reaches its target, does its job, and then gets cleared. Primarily through the liver, primarily through the kidneys. That cycle, from ingestion to elimination, has a specific duration. It is called the drug's half-life. And half-life is everything, because if a drug's half-life is 12 hours in a healthy 45-year-old, but the same drug takes 18 hours to clear in a 70-year-old with reduced kidney and liver function, the math changes in ways that accumulate dangerously over time. Take that pill every day, and by the end of the week, you are not carrying one day's dose in your system. You are carrying the overlap of several. The blood concentration climbs higher than it was ever supposed to, and the drug, at a dose nobody flagged as dangerous, starts producing effects that look like something else entirely. That is where the confusion begins. The liver's role in this is significant and worth slowing down on. The liver contains a family of enzymes called cytochrome P450, which are responsible for metabolizing the majority of pharmaceutical drugs. With age, liver mass decreases by roughly 20 to 30% between the ages of 20 and 70. Hepatic blood flow, the rate at which blood moves through the liver for processing, drops by somewhere between 30 and 40% over the same period. What that means practically is that drugs which depend heavily on liver metabolism arrive at their target in higher concentrations, stay active longer, and compete more intensely with other drugs using the same enzymatic pathway. That last point is critical. The cytochrome P450 system has specific subtypes, CYP3A4, CYP2D6, CYP2C9, among others, and many common medications are processed by the same one. When two drugs compete for the same enzyme, the slower one wins by staying in circulation longer. This is how drug interactions that seem unlikely on paper become genuinely dangerous in an aging body. Not because either drug is inherently wrong, but because the metabolic infrastructure that used to handle both is now stretched thin. The kidneys are the other half of this equation, and arguably the more consequential one for older adults. Glomerular filtration rate, the measure of how efficiently the kidneys are filtering blood, declines steadily with age even in people who are otherwise healthy. A person with perfectly normal kidney function at age 40 may have lost 30 to 50% of that capacity by 75. And unlike high blood pressure or elevated cholesterol, declining kidney function rarely produces noticeable symptoms in its early and middle stages. You feel fine, your blood pressure is controlled, your energy is reasonable, and all the while your kidneys are clearing drugs at half the rate the prescribing calculation assumed. The drugs most affected by this are ones excreted renally, meaning the kidneys are the primary route of elimination. This includes several common blood pressure medications, metformin used in type 2 diabetes, certain antibiotics, and some heart rhythm drugs. When kidney clearance drops, these medications accumulate. Their effective dose becomes higher than what was prescribed. And the symptoms of that accumulation, confusion, dizziness, fatigue, falls, are exactly the symptoms that get written off as just getting older. That misattribution is one of the most consequential errors in geriatric medicine. Now layer on top of this the shift in body composition. Between the ages of 40 and 70, the average person loses a significant portion of lean muscle mass and gains fat tissue, even without major weight changes on the scale. Total body water also decreases. These two changes affect how drugs distribute through the body in opposite but equally problematic ways. Water-soluble drugs like certain antibiotics, lithium and digoxin, depend on body water for distribution. Less water means a smaller volume for the drug to spread into, which drives up concentration in the bloodstream. The same oral dose produces a higher peak level than it would have a decade earlier. Fat-soluble drugs, by contrast, have more tissue to accumulate in. Drugs like diazepam, certain antidepressants, and many sedatives are highly lipophilic. They dissolve into fat. In an older body with more fat tissue, these drugs sink in, accumulate across deposits, and release slowly back into circulation long after the last dose was taken. The sedative effect that should have worn off by morning is still present at noon. The muscle relaxant taken 3 days ago is still influencing balance and reaction time. This is the physiological backdrop, and it sets the stage for understanding why certain drug categories, ones that are genuinely useful in younger adults and genuinely standard in medical practice, start producing a different risk profile after 60. The category most people are least suspicious of is over-the-counter pain relief. Ibuprofen, naproxen, and related non-steroidal anti-inflammatory drugs are taken by millions of older adults regularly for joint pain, arthritis, and general aches. They work. That is not in question. But in an aging body with reduced kidney function, NSAIDs create a particular problem. They constrict the blood vessels that supply the kidneys, reducing filtration further in an organ that is already working below capacity. Taken occasionally by a young adult, this effect is temporary and trivial. Taken regularly by a 70-year-old with already compromised renal function, it accelerates kidney decline in ways that are measurable, cumulative, and largely silent until the damage is done. There is also the gastrointestinal risk. NSAIDs inhibit the prostaglandins that protect the stomach lining. In younger adults, that protection rebuilds quickly. In older adults, the stomach lining is already thinner, recovery is slower, and the risk of ulceration and gastrointestinal bleeding climbs significantly. Studies have found that adults over 65 have roughly 3 to 5 times the rate of serious gastrointestinal complications from NSAID use compared to younger adults. And many of those older adults are also taking a daily aspirin or a blood thinner, which compounds the bleeding risk further in ways that add up quietly until they do not. Then there is polypharmacy, the clinical term for taking multiple medications simultaneously, and it is not a fringe situation. In the United States, more than 40% of adults over 65 take 5 or more prescription medications daily. In some surveys of adults over 75, that number climbs to 50% or higher. Add over-the-counter drugs, supplements, and herbal products, and the interaction landscape becomes genuinely complex. The problem is not just pharmacokinetic, it is also practical. Doctors who prescribe medication number 6 are not always reviewing medications 1 through 5 in detail. Each prescription may be perfectly appropriate in isolation. Together, they create overlapping effects, competing clearance pathways, and cumulative side effect burdens that no single physician fully mapped out. A cardiologist manages the heart. A rheumatologist manages the joints. A primary care doctor manages everything else. And in the gaps between those conversations, the patient is taking the full combination every morning without anyone watching the complete picture. That full picture is what this video is about. And the next piece of it is the most important, going through the specific drug categories that carry the highest risk after 60, explaining exactly why the risk shifts, and showing what the warning signs look like when something that should be helping is quietly doing harm. Every medication on this list is legal, widely available, and regularly recommended by doctors. Some are over the counter. Some have been taken without interruption for years. None of them are exotic, and that is precisely why this conversation matters. Because the danger is not in obscure compounds people have never heard of. It is in the familiar ones, the ones nobody thinks to question. Start with antihistamines because this is the category that surprises people most. Diphenhydramine sold under the brand name Benadryl and found inside dozens of combination cold, allergy, and sleep products, including Tylenol PM, Zizquil, and Unisom, is one of the most widely used drugs in the world. It is also one of the most explicitly flagged medications on the Beers criteria, which is the American Geriatric Society's official list of medications considered potentially inappropriate for adults over 65. And it has been flagged there for a reason. Diphenhydramine belongs to a class called anticholinergics. These drugs work by blocking acetylcholine, a neurotransmitter involved in a wide range of functions: memory, bladder control, digestion, heart rate, and cognition among them. In a younger brain, short-term acetylcholine suppression is manageable. The system compensates to maintain internal balance. In an aging brain, where acetylcholine activity is already naturally declining, particularly in people with early or undiagnosed cognitive changes, blocking it further produces effects that go well beyond drowsiness. The documented risks in older adults include acute confusion and delirium, urinary retention, constipation severe enough to require medical intervention, increased fall risk, blurred vision, dry mouth leading to dental deterioration, and with long-term use, an association with accelerated cognitive decline. A widely discussed study published in JAMA Internal Medicine tracked older adults over a decade and found that cumulative anticholinergic use was associated with a significantly increased risk of dementia. The researchers calculated anticholinergic burden by drug and duration, and the association held even after controlling for other variables. The deeper problem is that diphenhydramine is not just in Benadryl. It is in nighttime cold medications, combination pain and sleep formulas, and motion sickness treatments. Older adults who would never take a sleeping pill often take Tylenol PM without considering that the PM stands for diphenhydramine. They assume it is safe because it is on the shelf at the pharmacy without a prescription. And their doctor, who is focused on the prescription list, may never ask about it. Other anticholinergics carry similar concerns. Certain bladder medications like oxybutynin, some older antidepressants like amitriptyline, muscle relaxants like cyclobenzaprine, and some antipsychotics all carry significant anticholinergic load. When 2 or 3 of these are taken simultaneously, even at individually modest doses, the combined anticholinergic burden can produce profound cognitive and physical effects in an older adult that look indistinguishable from early dementia or general age-related decline. The symptoms are not dramatic. That is the problem. They are slow, gradual, and all too often they are easy to explain away. Now move to benzodiazepines and sleep medications, because this is the category with the most direct link to falls, fractures, and fatal accidents in older adults. Benzodiazepines include drugs like diazepam, lorazepam, clonazepam, and alprazolam, sold as Valium, Ativan, Klonopin, and Xanax respectively. They are prescribed for anxiety, insomnia, muscle spasms, and seizure control. In younger adults, they are effective and clear the system within a predictable window. In older adults, the picture changes substantially. Diazepam, for example, is highly fat-soluble. As discussed earlier, increased fat tissue in older adults means it accumulates and redistributes slowly. Its active half-life in a young adult might be 20 to 100 hours. In a 75-year-old, the effective duration can extend to 200 hours or longer because of slowed hepatic metabolism and fat accumulation. A dose taken on Monday may still be influencing balance and reaction time on Thursday, long after the person believes the drug has worn off. The consequence is impaired coordination, slowed reflexes, and altered depth perception, all while the person feels relatively normal, or perhaps just a little foggy. Falls in this state are not rare events. Among adults over 65, fall-related injuries are the leading cause of accidental death. And benzodiazepine use is one of the most consistently identified risk factors in the research literature. Hip fractures following falls carry a 1-year mortality rate of roughly 20 to 30% in older adults. A sedative that felt manageable at 50 becomes, at 75, a meaningful contributor to that risk. The Z drugs, zolpidem, ezopiclone, and zaleplon, sold as Ambien, Lunesta, and Sonata, were originally marketed as safer alternatives to benzodiazepines for sleep. For older adults, they are listed alongside benzodiazepines on the Beers criteria and carry many of the same concerns: residual sedation the following morning, increased fall risk, and in some cases complex sleep behaviors, including sleepwalking and sleep driving that the person has no memory of afterward. Both categories are also associated with physical dependence. Older adults who have taken a benzodiazepine nightly for years often cannot stop without medical supervision. The drug is no longer producing sleep so much as preventing the withdrawal that would otherwise occur without it. And because they have been taking it for so long, nobody, including their prescribing doctor, tends to initiate the conversation about stopping. Proton pump inhibitors come next. These are acid-reducing drugs: omeprazole, pantoprazole, esomeprazole, lansoprazole, sold as Prilosec, Protonix, Nexium, and Prevacid. They are among the most prescribed medications in the world and widely available without a prescription. They are highly effective for gastroesophageal reflux disease, stomach ulcers, and protecting the stomach during NSAID use. And for short-term use in clearly indicated cases, they are appropriate. The issue is duration. Proton pump inhibitors were designed and studied for short-term use, typically 4 to 8 weeks. In practice, many older adults have been taking them for years, sometimes indefinitely, often because no one reviewed whether they still needed them. Long-term PPI use in older adults is associated with several specific risks: magnesium depletion, which can cause muscle cramps, irregular heart rhythms, and fatigue; calcium malabsorption, which accelerates bone density loss and increases fracture risk; vitamin B12 deficiency, which in older adults can produce neurological symptoms, including numbness, balance problems, and cognitive changes that are frequently attributed to aging, rather than the medication causing them; and an increased susceptibility to certain gut infections, including Clostridioides difficile, because stomach acid, which PPIs suppress, is one of the body's primary defenses against ingested pathogens. None of these effects appear quickly. They develop over months and years of continued use. And because each symptom can be plausibly explained by the aging process itself, the medication rarely comes under suspicion. Blood pressure medications deserve careful attention here, not because they are inappropriate after 60. Many are essential, but because the relationship between blood pressure, medication dose, and the aging cardiovascular system is more delicate than most patients are told. As people age, the baroreceptors that help regulate blood pressure in response to position changes become less sensitive. Standing up quickly from a seated or lying position normally triggers an immediate compensatory response. Blood vessels constrict, heart rate adjusts, pressure is maintained. In older adults, this response is slower. Add a blood pressure medication that is doing its job of lowering pressure, And the result can be orthostatic hypotension, a sudden drop in blood pressure upon standing that causes dizziness, lightheadedness, and sometimes loss of consciousness. This is another significant fall risk, and it is one of the most under-recognized medication effects in older patients. Alpha blockers like doxazin, used for both blood pressure and prostate symptoms, are particularly associated with this risk. Some calcium channel blockers and diuretics also contribute. And when a person is taking 2 or 3 antihypertensives simultaneously, which is common in older adults with difficult-to-control blood pressure, the cumulative pressure-lowering effect can be aggressive enough to cause symptoms daily that they have simply adapted to as normal. Diabetes medications carry their own specific risk shift after 60, and metformin is the right place to begin, not because it is dangerous in most cases, but because its safety profile is directly tied to kidney function. Metformin is cleared renally. As kidney function declines with age, metformin clearance slows, and the drug can accumulate to levels that cause lactic acidosis, a buildup of lactic acid in the blood that can be life-threatening. Current guidelines recommend dose adjustment or discontinuation of metformin when kidney function falls below a specific threshold. But kidney function is not always being monitored as frequently as it should be in older patients on long-term metformin, and the threshold can be crossed gradually without warning. Sulfonylureas, drugs like glipizide and glimepiride that stimulate the pancreas to produce more insulin, present a different but equally serious concern. They can cause hypoglycemia, which in a younger adult typically produces obvious symptoms: shakiness, sweating, rapid heartbeat, hunger. In older adults, hypoglycemic episodes are more likely to present as confusion, weakness, and unsteadiness, symptoms that get attributed to fatigue or the aging process itself. And they are more likely to be severe when they occur because the hormonal counter-regulatory response that raises blood sugar becomes less efficient with age. Warfarin, the blood thinner used for stroke prevention and clot management, is one of the most carefully managed medications in medicine and one of the most sensitive to change in older adults. Its therapeutic window is narrow. Small shifts in diet, other medications, illness, or kidney and liver function can push the anticoagulation level either too low, leaving the patient unprotected, or too high, creating a serious bleeding risk. In older adults, the consequences of over-anticoagulation are particularly severe because minor falls produce bleeding events, including intracranial bleeds that would not occur in a younger person. And because older adults fall more frequently, the intersection of warfarin use and fall risk is one that requires regular, explicit evaluation, rather than routine prescription refills. The warning signs across all of these categories share a common thread, and it is worth naming it directly. Confusion that seems to come and go. Dizziness that is worst in the morning or when standing. Falls that are explained away as clumsiness. Fatigue that feels different from tiredness. Appetite changes. Mood shifts. Incontinence that appeared gradually. Muscle weakness without clear cause. These are not simply signs of getting older. They are also the clinical presentation of medication accumulation, drug interaction, and dose mismatch in an aging body. The problem is that they look identical, and without someone actively looking at the medication list as a possible cause, they get attributed to age and left in place, while the medication continues doing quiet damage underneath. That is what the final part of this video addresses directly, because knowing the risk is only half the equation. The other half is knowing what to do with that knowledge in a way that is safe, practical, and grounded in how medical care actually works. Knowing that certain medications become more dangerous after 60 is useful information, but information without a clear path forward creates anxiety, not change. So this final part is about action-specific, realistic, and safe action that works within the medical system rather than around it. The first and most important thing to say is this: do not stop any prescription medication on your own, based on what you have learned here. That instruction is not a legal disclaimer, it is a genuine medical caution. Several of the medications discussed in this video, benzodiazepines, certain blood pressure drugs, corticosteroids, and some antidepressants, carry real withdrawal risks when stopped abruptly. Others, like warfarin, require carefully managed transitions if a change is made. Stopping without supervision can produce outcomes more dangerous than continuing the medication while a proper review takes place. The goal is not to eliminate medications. The goal is to make sure every medication you are taking is still the right one, at the right dose, for the body you have now. That process has a name in clinical medicine. It is called a medication review, and it is something every adult over 60 should be requesting explicitly and regularly, not assuming it is happening automatically, because in most medical systems it is not. Here is what a proper medication review involves, and why it is worth asking for by name. A thorough medication review goes beyond looking at each prescription in isolation. It evaluates the full list: prescriptions, over-the-counter drugs, supplements, and herbal products together, against your current kidney and liver function, including your blood pressure patterns, as well as your recent lab results, and any symptoms you have been experiencing. It asks the question that does not get asked often enough in standard appointments. Is each medication still indicated, still necessary, and still dosed appropriately for this patient's current physiology? When you request this conversation, bring everything, not just the prescription bottles. Every supplement, every vitamin, every occasional over-the-counter product you use. Melatonin, fish oil, ibuprofen taken for joint pain a few times a week, the antacid taken nightly before bed. These matter, and they interact with prescription drugs in ways that your doctor cannot account for if they do not know about them. There is a practical framework that physicians and pharmacists use to evaluate medication appropriateness in older adults, and it is worth knowing it exists so you can reference it. The Beers criteria, published and regularly updated by the American Geriatric Society, is a research-based list of medications that are considered potentially inappropriate for adults 65 and older. It is not a banned list. It is not a definitive statement that everyone on those medications is being harmed. It is a clinical tool, a flag that says this drug warrants extra scrutiny in this age group, and that the risk-to-benefit calculation should be revisited more carefully than it might be for a younger patient. If a medication you are taking appears on the Beers criteria, that is a conversation to have with your doctor. Not a reason to stop it immediately, but a reason to ask, is this still the best option for me, given where my health is now? Are there alternatives with a more favorable profile for someone my age? Is the dose still calibrated to my current kidney and liver function? Those questions are reasonable. They are clinically appropriate, and a good physician will not be offended by them. If anything, the physicians who specialize in older adult care, geriatricians, consider medication reduction or deprescribing one of the most valuable interventions they can offer. Deprescribing is not giving up on treatment. It is recognizing that in an aging body, fewer medications used more precisely often produce better outcomes than more medications used broadly. Ask your primary care doctor about a deprescribing review if you are taking 5 or more medications regularly. Ask whether your kidney function has been tested recently, and whether your current medication doses were calibrated to those results. Ask specifically whether any of your medications carry an increased fall risk, not because you plan to stop them, but because knowing allows you to take practical precautions in the meantime, like modifying your home environment, adjusting when you take the medication, or changing how quickly you move from lying to standing. There are also specific red flag symptoms worth knowing because they represent the body signaling that something in the medication picture may have shifted. Sudden or worsening confusion, particularly if it fluctuates across the day, is one of the clearest signals. In older adults, this presentation is called delirium, and medications are among its most common causes. It is not a psychiatric event. It is a physiological one, often reversible when the offending drug is identified and addressed. If someone you know over 65 develops confusion that appears relatively suddenly or seems to come and go, medication accumulation or interaction should be among the first things considered, not the last. Dizziness upon standing, especially if it is a new symptom or has worsened, warrants evaluation of blood pressure medications and anything else with pressure-lowering effects. Falls that seem to happen without obvious cause, particularly in the morning or after taking medications, should prompt a review of sedatives, muscle relaxants, blood pressure drugs, and anything with anticholinergic properties. Unusual fatigue, appetite loss, or muscle weakness that has appeared gradually should not be assumed to be aging. These can be the presentation of thyroid medication imbalance, statin-related muscle effects, or accumulation of drugs that are simply not clearing efficiently enough. Gradual cognitive changes, slower thinking, memory gaps, word retrieval difficulty should prompt a review of anticholinergic burden before any assumption of dementia is made. In some cases, stopping or switching a single medication produces a meaningful and relatively rapid improvement in cognitive clarity. Not always, but often enough that it deserves to be ruled out first. Gastrointestinal symptoms, chronic nausea, constipation that has worsened over time, stomach pain, are frequently medication effects that have been normalized. Constipation in particular is strongly associated with opioid pain medications, calcium supplements taken at high doses, anticholinergic drugs, and iron supplementation, among others. Assuming it is dietary when medications are present is a common and correctable mistake. The practical bottom line is this: at 60 and beyond, your relationship with medication needs to become more active, not more passive. The reflexive trust in a prescription that was written 5 years ago and has been refilled ever since is not a safe default at this stage of life. Physiology changes. Kidney function changes. Body composition changes. The drug that was perfectly calibrated for you at 58 may be quietly mismatched with the body you have at 71. And the only way to find that mismatch is to look for it deliberately. That means scheduling a dedicated medication review rather than waiting for it to happen during a routine appointment already crowded with other concerns. It means bringing the complete list, including everything over the counter. It means asking direct questions about kidney function, fall risk, and alternatives. It means not assuming that because a prescription is being refilled, someone has recently decided it is still the right choice. It also means paying attention to your own body with the understanding that what you have learned today gives you a better framework for interpreting what you feel. The dizziness in the morning is not just age. The foggy thinking is not just tiredness. The balance that has quietly gotten worse is not inevitable. These are signals, and signals are information. The broader takeaway from everything covered in this video is not that medications are enemies or that the medical system has failed older adults. It is something more specific and more actionable than that. The system was built around population averages, and the aging body is not average. It requires a more individualized, more attentive, and more regularly updated approach to what goes into it. You are not powerless in that process. You are, in fact, the person best positioned to initiate it. Because you know your full medication list, you experience your daily symptoms, and you are the one living in the body that all of this affects. The conversation your doctor needs to have with you is one that you may need to start. Now you know what to say. If this video gave you something useful, a question to ask, a symptom to reconsider, a conversation to have with someone you care about, share it with them. These are the things that deserve to travel further than an algorithm decides they should. And if you want to keep receiving this kind of clear, grounded medical information, subscribe to this channel. There is a great deal more that does not get explained the way it should be. We will keep explaining it